Good afternoon, ladies and gentlemen. Thank you for joining us the APSC JCS 2020 webinar 7. It's okay. Hypertension Guideline and Future Practice in Asia. I'm Naoyuki Hasebe from Asahikawa, Japan. I will chair this session together with great Professor Jiguang Wang from Shanghai, China. It's our great pleasure and honor to organize this session despite the many difficulties related to COVID-19. Today we have distinguished speakers for this session. Professor Shanghai Park from Korea. Thank you for coming. And Professor Tzung-Dau Wang from Taiwan. Unfortunately, he is not present today, but his recorded presentation is here, so we can enjoy that. So that won't be a problem. And Professor Mitsuru Oishi from Kagoshima, Japan. Thank you for coming. We hope everybody enjoyed this 90-minute session on hypertension management in Asia. So let's start the session. At the beginning, I will give you a brief talk as an introduction. Oh, oh, um, overview of hypertension in Asia. At two, oh, this is my COI. At 2,972 million people were hypertensive worldwide. It was estimated to increase to 1.56 billion at 2025. Switching of dominant sex in hypertension from men in 2000 to women in 2025 may reflect the longevity of women. One third of patients live in developed countries, and the remaining two thirds live in developing countries. According to WHO Global Health Observatory data 2015, raised blood pressure is estimated to cause 7.5 million deaths, about 12.8% of the total of all deaths worldwide. The risk of cardiovascular disease doubles for each increment of 20 over 10 millimeter mercury of blood pressure, starting as low as 115 over 75 millimeter mercury. Across the WHO regions, the prevalence of raised blood pressure was highest in Africa, where it was 46% for both sexes combined. This map shows a distribution of raised blood pressure in female worldwide. And the higher prevalence shown in red or dark orange indicate the prevalence is prominent in Africa and Eurasia. Here is Yemen and Afghanistan. In male, the prevalence of hypertension is more marked in Africa and the Soviet Union. Here is Afghanistan and Pakistan in Asia. This map shows those of both sexes combined. The number of adults with hypertension were 1.13 billion in worldwide in 2015. 258 million, 23% live in South Asia, mainly in India, and 235 million, 21% live in Asia, East Asia, mainly in China. Hypertension is the most influential factor contributing to cardiovascular deaths in Japan, and the annual number of deaths due to hypertension was estimated to 100,000, which was twice or three times greater than other factors, physical inactivity, smoking, hyperglycemia, and high LDL cholesterol levels. Cardiovascular death rates for coronary heart disease were greater than those for stroke in many Asian countries. In Western Asia, for example, in blue, like Saudi Arabia, and in Central Asia, in pink, like Uzbekistan, and in Middle East Asia, in light green, like Iran, and in Southeast Asia, in orange, like Indonesia. In contrast, those for stroke were dominant in Korea and Japan and China, shown in red. So accordingly, when the greater stroke mortality in excess of coronary heart disease mortality is expressed in red or dark orange areas, those were prominent in China, Mongolia, and Thailand, Korea, and Japan. There were a strong positive association of blood pressure with total cardiovascular death in Asia and Australasia. Particularly, the relation was significantly steeper in Asia. The lower panel of bar charts show the content of events. The major event was stroke in Asia, shown in light blue, and in contrast, it was ischemic heart disease in Australasia, shown in pink. It shows a typical contrast. Even within Asia, there are marked differences in hypertension awareness, treatment, and control rates between countries. For example, the control rates were ranging from 5.5 to 70%. Diversity of genetic background, culture, lifestyle, environment, and so on contribute to the heterogeneity. Despite remarkable advances in the diagnosis and treatment of hypertension, countermeasures against hypertension are still insufficient. The ratio of unaware and untreated patients with hypertension was 33%. Therefore, the estimated awareness ratio of hypertension is 67% in Japan. The ratio I estimated, the treated ratio of hypertension was barely more than half, 56% in Japan. Out of 43 million patients with hypertension, only 12 million, that means only 27% of patients have hypertension well controlled. This hypertension paradox is a serious clinical problem in Japan. Here's the classification of blood pressure levels in adults in Japanese Society of Hypertension JCS Guideline 2019. Hypertension is defined as office blood pressure more than 140/90 millimeter mercury, which was same as the previous guideline JCS 2014. Normal blood pressure was defined less than 120/80 millimeter mercury, and normal and high normal pressure were categorized in normal range. So between both categories, elevated blood pressure range is identified neither normal nor hypertension, but pre-hypertension range. A diagnostic threshold for hypertension is more than 140/90 millimeter mercury in almost all countries in Asia. As for the target level of blood pressure control, some countries recommend a lower threshold less than 130/80 millimeter mercury. consistent with the European and US guidelines. The US guidelines recommend the same blood pressure target for all patients with hypertension regardless of comorbidities. In contrast to the US guideline, many Asian countries recommend a different target blood pressure depending on the comorbidity and risk profile, for example, diabetes and CKD. When we adopt lower target blood pressure levels, the ratio of well-controlled patients consequently decreased further. This is a new logo mark recently selected by Japanese Society of Hypertension to facilitate good control of hypertension for achieving blood pressure control levels less than 130/80 millimeter mercury. The effects of antihypertensive treatment on cardiovascular disease depend mainly on the degree of blood pressure reduction rather than the class of antihypertensive drug. In Eastern Asia, CCBs and ARBs are widely used as a first-line drug in most countries. The combination therapy is often required to achieve blood pressure control. Thus, use of monotherapy is around 40% on average. Asians have an unfavorable tendency of high salt intake, which combined with greater salt sensitivity in Asians than in Caucasians. This figure is from British Medical Journal indicating high sodium intake in Asian countries. In the left panel, Asian countries were highlighted by red squares. And in the right map, the countries reported high sodium intake shown in red and orange, dark orange areas, including Japan. This is a mascot character for salt restriction campaign in Japan. His name is Yoshio-kun, meaning good salt in Japanese. He's 6 years old, and 6 is associated with the goal of salt restriction less than 6 grams per day. He put on a measuring spoon as a cap and is always measuring his blood pressure, symbolizing highly awareness of hypertension. The sign indicated 17th of every month is enacted as Salt Restriction Day by Japanese Society of Hypertension. For prevention of hypertension, lifestyle modification is unquestionably important. Salt reduction less than 6 grams per day, and increase in vegetable, fruit, and fish intake, and decrease in cholesterol and saturated fatty acid, and body weight control and exercise, reduction of alcohol intake and smoking cessations are all strongly recommended. The valid factors contributing to hypertension and cardiovascular disease in Asia are summarized in this figure. Diversity of genetic background, culture, urbanization, and environment, lifestyle-related disorders and comorbidities all contribute to the heterogeneity of hypertension in Asia. Thus, we need to share our knowledge and information to facilitate best practice for the effective management of hypertension and prevention of cardiovascular disease. That's all for introduction, and thank you for your attention. Let's start the session. Let's move on to the first speaker, Professor Jiguang Wang from Shanghai, China. The title of his talk today is Current and Future Hypertension Guideline in China. Professor Wang, please.
Ladies and gentlemen, it's a great pleasure for me to give a presentation in this symposium. My name is Jiguang Wang from the Shanghai Institute of Hypertension. I should thank the organizers of the meeting to give this opportunity for me to present the Chinese hypertension guideline. That's my disclosures. The most recent Chinese hypertension guideline was published in 2018, both in the Chinese language and in English. In these 2018 Chinese hypertension guidelines, we did not redefine hypertension. As you may see here in this slide, we can see the details of the blood pressure classification in these new Chinese hypertension guidelines. We classify normal blood pressure in 2 different levels and hypertension in 3 stages. This is different from the recent American hypertension guidelines. You're all aware that in the American hypertension guidelines, they redefined hypertension as 130 over 80. So it means that they changed the previous definition of 140 over 90 to the new threshold 130 over 80. However, in the Chinese hypertension guidelines, we also recommend the use of out-of-office blood pressure measurement. As you may see here, we recommend the use of ambulatory and home blood pressure monitoring to define hypertension. So in this regard, we have similarities as most of the hypertension guidelines, the American guidelines, and the European hypertension guidelines also published in 2018. Chinese hypertension guidelines, we continued these cardiovascular risk assessments and stratification according to both systolic and diastolic blood pressure and cardiovascular risk factors and complications. On the left hand, you see those risk factors and complications. On the horizontal axis, we have different levels of systolic and diastolic blood pressure. One of the new recommendations is on the left column of systolic and diastolic blood pressure. So it means that we would also treat those people with a slightly lower systolic or diastolic blood pressure below 140 over 90 if a patient would have a higher cardiovascular risk. Chinese hypertension guidelines, we continued recommending various blood pressure target of treatment according to age. As you can see here, in general, we treat to 140 over 90 or 130 over 80 as an intensive blood pressure target. But in those older than 65 years, especially those older than 80 years, we treat to a less stringent target. Here you see 150 over 90 millimeter of mercury. And in those between 65 and 79, and we can also treat to 140 over 90 if tolerable. Choice of antihypertensive drugs. Chinese hypertension guideline recommends 5 classes of antihypertensive drugs as a primary agent, or in other words, a first-line agent for antihypertensive treatment. And the difference is about the use of beta blockers. Here you see in these Chinese hypertension guidelines, we continue recommending the use of beta blockers as a primary agent of antihypertensive treatment. For the choice of a combination therapy, the Chinese hypertension guidelines have a little bit different recommendations from other hypertension guidelines. Here you can see we recommend, similarly as other hypertension guidelines, the combination of calcium channel blocker with a ACE inhibitor ARB or a thiazide diuretic with ACE inhibitor ARB. But in addition, in this Chinese hypertension guidelines, we also recommend the combination of a calcium channel blocker with a thiazide diuretic or beta blocker. as a preferred combination. Then we can compare the Chinese Hypertension Guidelines 2018 with the very recently published International Society of Hypertension Guidelines, the so-called ISH 2020. So here we can compare various characteristics of these two different guidelines. You see, these two guidelines have a lot of similarities, but they do have quite different recommendations, for instance, in the blood pressure classification. And another major difference is the choice of initial drug treatment and for both monotherapy and for combination therapy. As you may see here, the International Society of Hypertension Guidelines recommend early use of single pill combination therapy, especially the combination of a calcium channel blocker with an ACE inhibitor or ARB. The target, the two guidelines are also slightly different. In general, the Chinese hypertension guideline is a little bit conservative in the therapeutic target. Here you can see in the elderly, younger or older elderly, and we tend to recommend a less stringent therapeutic target. But in the International Society of Hypertension Guidelines, they recommend 130/80 in general and 140/90 in those elderly hypertensive patients. If we would consider the International Society of Hypertension Guidelines as a background for the future Chinese hypertension guidelines, how we are going to develop a new hypertension guidelines in China. And in this next few slides, I would present some personal ideas myself. So if you look at blood pressure classification on the basis of clinic measurement, here you can see my personal view is to simplify the classification according to clinic blood pressure. I would be in favor of two levels of normal blood pressure, normal and high normal, and two levels of stage 1 and stage 2 hypertension. So I personally prefer to define severe hypertension in those people with a systolic blood pressure of 180 or higher, or a diastolic blood pressure 110 or higher. In the meantime, I would be in favor of using automated clinical blood pressure measurement. Here you can see we recently established infrastructure for blood pressure measurement in our outpatient clinic. The patients measure blood pressure themselves, and the blood pressure readings would be automatically transmitted to the hospital information system, and the doctors can look at those blood pressure readings when they see the patient. We probably have to rely more on ambient blood pressure measurement in the diagnosis of hypertension. You can see from this slide, we can actually classify blood pressure according to ambient blood pressure measurement, and we compared outcome-driven thresholds with the threshold recommended by the American Hypertension Guidelines. You can see here they are slightly different. This slide is a little bit busy and complex. I would have to explain to you carefully. On the left hand, you have home blood pressure. On the right hand, in 3 panels, you have ambient blood pressure. On the very right hand, you have actually the 24-hour blood pressure. Here you see is the association between systolic blood pressure and the risk of cardiovascular events in 4 different age groups. On the bottom, you have those people younger than 60 years. On the upper part, you have 3 older age groups. And the association is much stronger in those younger than 60 years than the 3 older age groups. Home blood pressure monitoring is similarly important as ambulatory blood pressure monitoring. Uh, We recently published the 2019 Chinese Hypertension League home blood pressure monitoring guidelines. As you may see here, we recommend the use of home blood pressure to define hypertension. And here we can find those people with the so-called white coat hypertension and those with masked hypertension. In the new Chinese hypertension guidelines, we probably also have more recommendations on screening for the so-called secondary hypertension. As you may see at the scheme from the American hypertension guidelines, they recommended those people with new onset or uncontrolled hypertension for the secondary hypertension screen if they have the conditions listed in this box. So in the new Chinese hypertension guidelines, we probably will have to do the similar thing to screen those people with secondary hypertension. In addition, we probably should also look after those emerging diseases, for instance, atrial fibrillation. We are living in an aging world. We have more and more people over 60 years, or even 80 or 90 years. And atrial fibrillation is a very typical age-dependent disease. Only in those people over 65 or 75 years, you would see a higher prevalence of atrial fibrillation. So we probably have to do more research in patients with both hypertension and atrial fibrillation. And in the meantime, we probably need also recommendations for this special group of patients with the two diseases, hypertension and atrial fibrillation. Finally, I would say a few words on the general principles of the new Chinese hypertension guidelines. The new guidelines to be goal-driven, so we have to focus on blood pressure control. We set up a new goal for 2030, and we want to improve blood pressure control rate from the current 15 to 16% to 50% by 2030. Second, the new guidelines has to be technology led. So we have to recommend the use of new technology, for instance, artificial intelligence or telemedicine. And the third, we have to balance idealism and practicability. So the guideline has to be ideal, but has to be practical as well. Thank you. Thank you very much.
We should consider the order of the presentation, but how can we manage the Professor Wang from Taiwan? His presentation is already recorded, so we can enjoy that soon. But we need more time for Professor Wang in China. Wang is disconnected again. It's work.
Dear Chairman, ladies and gentlemen, it's my great honor to be invited to present in the Asian Pacific Society of Cardiology meeting. I'm Dr. Tzung-Dau Wang from National Taiwan University Hospital. I'm also the current president of Taiwan Hypertension Society. The talk I will give today, entitled Current and Future Hypertension Guidelines in Taiwan. I will introduce you first the current status of hypertension control in Taiwan, and second, the key features of 2015 and 2017 Taiwan Hypertension Guidelines, and finally, the new findings or new recommendations of the upcoming Taiwan Hypertension Guideline, which is in preparation and will be published in later this year or maybe in the early of 2021. As you all know, the prevalence of stroke is much higher in Asia or Asia Pacific region. And given the close relation between the hypertension and the stroke, we may judge that Asian Pacific people are more vulnerable to hypertension. So a more aggressive hypertensive control approach should be adopted in this region. And in Taiwan, well, we achieved a significant reduction of stroke mortality in the past 30 to 40 years. As you can see here in the age-adjusted mortality rate reduction of about 75%. That's a huge number. But even though the prevalence of stroke is still high in Taiwan, and even though we achieved such a great reduction in the adjusted stroke mortality rate, the recent published investigation of the whole Taiwan people, hypertensive people, we can still see the insufficiency in our management. First, 1 in 4 hypertensive people didn't know they got hypertension, and the overall control rate is about 50%. The 50% number is actually quite good compared to the rest of the world. However, for any chronic disease, we want to achieve 100% control rate. So there is still a long way to go to achieve such a goal. So these facts reflects the importance of the implementation of the hypertension guidelines. And then I will introduce you some key features of our published 2015 and 2017 guidelines. We published the first edition of Taiwan Hypertension Guideline in 2010. And 5 years later, we revised the guideline to issue the second edition of Taiwan Hypertension Guideline. And after the publication of the spring trial, which has a great impact on our daily clinical practice, so we published a focus update in 2017. And 5 years after 2015, in this year, we are now in preparation of the new Taiwan Hypertension Guideline. In our previous 2 versions of the guideline, 2 editions of the guideline, we want to make it more clinically useful. So we created algorithms, 3 algorithms, and to make the cartoon figures to facilitate its implementation. The first algorithm is called a diagnostic algorithm. In this algorithm, we emphasize the diagnosis of hypertension should be based on 2-step confirmation. So the first, it's not only solely depend on the office blood pressure. Once we measure the office blood pressure to be high, greater than 140/90, we have to examine whether there's a presence of target organ damage. If there is a target organ damage, the pharmacological treatment should be initiated immediately. But if there's no evidence of target organ damage, and then we have to check either home blood pressure or ambulatory blood pressure, and to confirm the diagnosis of hypertension. And the definition of home blood pressure for hypertension is 135/85, and the definition for ambulatory blood pressure is 130/80. So that's consistent with the level recommended by the international guidelines. And the blood pressure targets, besides the rest of 2 algorithms I will introduce, the blood pressure targets, we recommend the risk-based blood pressure targets, 140/90 for the general hypertensive patient and 130/80 millimeter mercury for high-risk hypertensive patient. The definitions of high risk include diabetes, chronic kidney disease with proteinuria, coronary heart disease, or patient taking anticoagulants or antithrombotic agents. So that's the risk-based blood pressure targets. And the second algorithm is about treatment algorithms. We also created some acronyms to facilitate memorizing. The first algorithm is called ACE-ABCDE, that represents the 6 sectors of lifestyle modification. We also create another acronym called PROCEED to include the 7 sectors of the hypertension management. And we separate the patient into high risk, the target 130/80, and the general hypertensive 140/90. We recommended the early and first line use of single pill combination in patients with stage 2 hypertension, but not all hypertensive patients. And finally, the last algorithm is called adjustment algorithm because for any chronic disease, it's not only important in the initial assessment and recommendation, but how to evaluate the long-term management. The adjustment algorithm is very important. We created another acronym called GOALS here to represent the 7 important aspects of long-term management. The first A means adherence. If the patient got poor adherence, maybe single pill combination could be used as a tool to improve the adherence. And the timing is also very important. We recommend to adjust the timing of the medication based on the home blood pressure monitoring or ambulatory monitoring. And the G means greater dose, O means other classes, A alternative means the different adjustment of antihypertensive medications. And finally, the double L means the lifestyle modification should be emphasized continuously. And the serial assessment of laboratory findings, because that could reflect the severity of target organ damage, and that be closely related to the outcomes that be emphasized in our 2015 hypertension guidelines. So that's the features of our old guidelines, and then what's new for our upcoming power hypertension guidelines. Basically, there are 3 new recommendations. The first is about the blood pressure targets. Blood pressure target is always the hot topic of any guidelines. But in the recent published American and European guidelines, there's some difference in the blood pressure targets. Whether we should consider J-curve and other aspects, we consider all the things, and we think that this figure can clearly demonstrate all the things we have to consider in recommending blood pressure targets. The first, the benefits of blood pressure reduction is directly proportional to the baseline risk rather than blood pressure severity. And as you can see here, and the so-called J-curve or risk associated with too aggressive blood pressure reduction actually is related to the severity of blood pressure. So for patients with much higher blood pressure, if we set the same goal, the blood pressure reduction will be much greater in those with a higher baseline blood pressure, therefore the greater possible side effects. So if we consider these 2 important principles, we can construct such a risk and grade-based blood pressure targets. We make this figure more clinically oriented or useful. We separated based on the stage and the grade in the blood pressure target into 2 targets. For those with a higher baseline risk, no matter how severity the blood pressure hypertension is, we suggested 125/80 targets. Well, this target is a bit lower than the 130/80 because the recent meta-analysis demonstrated that the blood pressure reduction down to below 125 is associated with the mortality reduction. And for those with even higher blood pressure, but if their baseline risk is not so high, we recommend 140/90 targets. Well, these are based on the HOPE-3 SPRINT post-hoc analysis and all the other meta-analysis. So that's the first new recommendation in our Taiwan hypertension guideline. We constructed risk and grade-based BP targets. And the second, we expand our initial recommendation for the first line or early use of single pill combination to all hypertensive patients, which are recommended also in all the international or regional guidelines recently published. And the final, we constructed the management or follow-up assessment algorithm. We first define the goal attainment have to fulfill the 3 criteria. The first is about office blood pressure for sure, and the second, home blood pressure or ambulatory blood pressure should be considered as a criteria for the goal attainment. And finally, the target organ damage, because this is the single factor that mostly closely related to outcomes. And the target organ damage or the severity of target organ damage or hypertension mediated organ damage should be remain stable or even reverse that could be defined as the goal attainment. So if we define the goal attainment, the definition of goal attainment should be based on the fulfillment of all these three criteria. And we also emphasize the importance of ambulatory blood pressure monitoring. We put the role of ambulatory blood pressure monitoring into this algorithm, and we recommend the ambulatory blood pressure monitoring should be performed in the following two conditions. The first is the presence of white coat hypertension, and the second is the persistent or progressive organ damage. If the organ damage cannot be reverted, we have to examine the ambulatory blood pressure monitoring. So these are the three new findings in our upcoming Taiwan Hypertension Guideline. So in summary, there are 4 points. The first, given the benefits of blood pressure lowering directly proportional to the baseline risk rather than the severity of blood pressure. So an integrated hypertension stage and a grade-based blood pressure target strategy being recommended in our upcoming guideline. And the initial single pill combination therapy will be recommended for all hypertensive patients. And the role of ambulatory blood pressure monitoring will be emphasized and clearly delineated in the algorithm to facilitate its clinical adoption. And finally, either home or ambulatory blood pressure monitoring or hypertension-mediated organ damage guided treatment strategy will be developed in our upcoming hypertension guidelines. Thank you for your attention.
Thank you, Professor Wang. Actually, he's not present today, but we enjoyed his presentation. We cannot discuss, but could you have give us some comment about the Taiwan hypertension guideline, Professor Park?
I agree with that you have to categorize different target blood pressure according to the risk, but I'm not sure what the number 125 came from. I don't know where the evidence is that the blood pressure should be lowered below 125. I think they're basing it on the blood pressure achieved blood pressure level from the sprint study, but the sprint study actually used the AOBP method, and I don't think you can generalize the results from the sprint study to the usual office blood pressure. So there's some question with the target blood pressure.
Oh yeah, next time we will ask him. Okay, Professor Oishi, do you have any comments on?
I have the same question. So because 120 is very, very strict. So I have one question.
Yeah, okay. So Professor Wang has some problem for connection, still on and off his condition. So we close this session at this time. And please enjoy the Professor Wang's presentation by on demand later. Thank you for joining us. Thank you, Professor Park, Professor Oishi. Thank you very much.
I would close the meeting by thanking all the speakers from several countries in Asia, all participants of the meeting, and my co-chair, Professor Hasebe. I should also thank the organizers of the meeting for their strong technical support, which allows us to communicate in this virtual online meeting. Thank you all.